So welcome everybody. I would like first to thank the ESCVS to make this webinar about the Elana heart bypass technology possible. Give a short introduction about the Elana technology, where we are coming from, and then we'll leave the floor to the real specialist to give a more insight about the Elana technology in CABG, in an open setting and a mid-cap setting. So where we were coming from is we already started in 2007 in neurosurgery, where we have proven the Elana technology to treat brain aneurysms or tumors in the brain. 2010 we got CE approval, FDA approval with the Elana technology, and the amount of patients is quite small. It was life-saving. But at that time, we know if we can make a bypass through the brains on a tiny vessel, why not between the ribs on a beating heart? So in 2012 already, we developed the whole technique to make it suitable on the beating heart. 2017, we founded AMT Medical, completely focused on CABG, and make the Elana heart bypass technique suitable on the beating heart. So in 2020, I think now 3 years ago, also Charité and Antonius did a lot of preclinical work, to do all the work to start our first human trial in an open setting in collaboration with Charité at Antonius Hospital. So the real founder of the Elana technology in neurosurgery was Professor Kees Tulleke. He's the father of our CEO, Rutger Tulleke. Was what I just mentioned. I also started there in 2007. We're quite sometimes, and like 15 years already on this technique. So there you are. Of course, you know better that in the past there were a lot of other companies working on connectors. But the advantages of the concept in neurosurgery was that we cannot occlude there a vessel in the brain, so we have to think differently. And Professor Tulleke came with the idea to first make a connection and then make the arteriotomy with a laser catheter. And that's that concept we developed to cardiac surgery. So we started the first patients in Antonius Hospital in an open setting, and I want to move from here. What Bart and Patrick, Dr. Putte and Patrick Klein, think about the advantages of a connector in an open setting. So Bart, I want to give the floor to you. Or Patrick.
Yeah, well, thank you, Glenn. I think a very interesting and nice overview and introduction. And maybe before we start to focus on this technology, I think it's very interesting to remind everyone to the fact that cardiothoracic and cardiovascular evolved in a very minimally invasive direction during the last 20 years. But the strange fact is that for a majority of patients just still need CABG, and actually nothing changed in CABG surgery the last decades, except for off-burn bypass surgery. And that is actually very remarkable, and also shows us that there is a huge challenge to overcome, to make or to enable minimally invasive or less invasive CABG surgery. And I think it's a great effort from AMT Medical, based in Utrecht in the Netherlands, that they were able to change this technology that was actually designed for neurosurgery, like you already said. And the problem to change this technology to cardiac surgery, it has that these devices have to be much smaller, and they have to work perfectly in order to make sure that the anastomosis that we want to make are at least non-inferior compared to the bypasses that we make each day by sutures. And so I think I want to congratulate you guys that you were able to change these devices, and that we were already able to do preclinical work in an animal setting, and overcoming all the difficulties and the learning curve problems. Yeah, we basically found out that the let's say the trick to manipulate and to work with these devices is actually not difficult. It is quite comparable compared to all other kinds of surgery. It's just a matter of doing it a couple of times to standardize the steps that you have to make. And in the end, we can see that it is working actually quite well, at least based on our experience on preclinical research and a little in human setting so far. So maybe I will give over the word to Predek in order to make sure that I'm not talking for half an hour. Maybe Predek, you can tell us a little bit about the preclinical work and the change that we made to the clinical setting last year, and maybe the direction we want to go to, let's say, in the very short upcoming period.
Yeah, thank you, Bart. So I think we made so as Bart rightfully said, we experienced. I mean, the devil's in the details. I think we already proved in preclinical work that we can make a durable facilitated anastomosis in the pig. Only there are some issues to overcome, as you rightly said, which has to do with the contact the laser makes with the tissue. So the depth that the laser, let's say, pushes on the tissue, the stabilization of the laser catheter in the clip, and the temporary fixation. That all plays a major role. That was what we found out in the preclinical work, and what we continue to do in the clinical work. Maybe it's a good idea to go, maybe show a little animation for everybody about the procedure, which gives a nice overview about how it works. So this is basically standard chest opening. Of course, we will speak about minimal invasive surgery later. Standard IMA harvesting. So here's the donor vessel and the upper fork of the clip. So the clip, this is the device, as you've shown. It consists of a body, an upper fork, a middle ring, and a lower fork. So the both rings can move independently from each other. We start with the upper fork. We open it, place it into the vessel, make sure you don't get the back wall, close it, and then the clip is in place. Then we temporarily occlude the IMA. We take the distal end, put in the laser catheter, and it docks perfectly into that little ring. What has to be exactly in place and not move, otherwise you don't get perfect contact. So then we stabilize it, and then we activate the laser for 2 or 3 times. If the vessel will stick, we use multiple laser actions. Then we push the catheter a little bit further to accommodate the distal distance from the vessel wall, open the lower fork, insert it into the donor, and then we repeat the whole sequence, getting an additional flap. The flap is temporarily being kept in position by vacuum, so it doesn't go into the bloodstream. And then we retrieve the catheter with the flap, and then we have our bypass once we clip the distal end. So, and how we see this is that this will facilitate or enable doing this from a greater distance to a smaller incision in the chest wall. I mean, suturing with an 8-0 suture and a small needle at a 20 centimeter distance to an LED is possible in very experienced hands. But I think we've all seen and experienced also that it's not that easy sometimes. And to have a reproducible, standardized anastomosis, which is being applied in an easier way, is in our view the way to go to move minimal invasive coronary surgery forward. So here you see the data that we presented last year about our. So the trial we did consists of 2 phases. Phase 1, after the preclinical work, was first a human trial. 6 patients were operated in Antonius Hospital, standard CABG patients. And we decided for safety reasons, so say, well, let's start with a smaller diameter diagonal branch, also for safety. If there are issues, there's still the main graft is still in place to the LED. So we did 9 males, 1 female, normal ventricles, We did that by anastomosing first an arterial graft to the EMA, mostly the right arterial mammary artery. And then we used that to construct a bypass onto the diagonal branch. So 100% flap retrieval. And so we did need some additional stitches. You see here that the mean graft flow is about 16 milliliters, and the pulse TDX mean of that's 2.1. If you look at the range of the data, which we've shown last year, you see that its range is between index of 1 to 3. So at worst, a pulse TD index of 3 and a good graft flow with good diastolic filling percentages. Of course, we did have some issues, as happened always. So we have done dislocated clip because of a ventilation maneuver to recruit the lung while we were doing flow measurements, and it dislocated the clip. And there was pulmonary embolism in one of the patients, and because some patients were operated urgently under dual antiplatelet therapy, we did experience cardiac tamponade, one with asystole. All patients recovered fine. There were no myocardial infarctions, no real events. We were free from major adverse cardiovascular events up to post-operative day 30. So this is basically how the first in human phase of the trial looked like. And with this data, our data safety monitoring board, and here you see an example of one of the clinical cases where we when we construct the graft, we got permission to continue phase 2, which is an additional 65 patients to be operated both in Berlin and in the Antonius Hospital. So on the left you see a movie. Oh, can we go one more back? Left you see the movie where we anastomose the arterial graft onto the diagonal branch, inserting the lower fork into the vessel wall, with the whole complex, stabilizing it, in this case by an octopus and a apical suction device. So we use a little bit of field flush to make sure that we really into the vessel wall. So if we go into details, I mean, these are one of the essential points, that you don't take back wall or side wall, we really into the ventricle. And then you see the middle picture, you see that we activate the laser. We activate the laser, we create the anastomosis, then we remove the temporary fixation clip, and we remove, so here goes the fixator off, here goes the fixation clip off. And then we take the laser catheter out of the vessel wall. There's a little vacuum because the vacuum of the laser keeps the flap in position, so we take it off. And here's the constructed graft when we luxate our. So this is a Y graft with an IMA to the LED and a second IMA RIMA to the diagonal branch. So and now we are excitingly in the second phase for the initial 65 patients. I think it's very important to mention that we will go from the diagonal target, since we didn't experience any MACE. We'll move from the diagonal to the LED as the main target for this procedure. So
maybe thank you, Patrick. I think it's a very nice overview of what we clinically have done and plan to do next year. Maybe it's interesting also to talk about future perspectives and why we are actually doing this. Maybe Stefan, can you comment on this? What your personal perspective is based on the things that we have done and the possibilities that are still open?
Yeah, thank you very much, Bart and Patrick, for this excellent overview of the Elana technique. So in general, I guess we, as a surgeon, we should be in a very comfortable position regarding the data for bypass surgery compared to interventional treatment. But one of the major issues for patients and for cardiologists, decision-making, is the invasiveness. And so there is need to become more and more less invasive. And that's why the focus is on the minimal invasive approach, achieving the LID, but also in we call it multi-vessel mid-cap, to achieve the complete arterial revascularization. And you all know the minimal invasive access is very challenging. It's a very demanding environment. And to make sure to achieve a reproducible, excellent anastomosis, to achieve these excellent outcomes of bypass surgery, I believe an anastomotic device is very helpful or at least mandatory to reach through this minimal invasive approach all the target vessels. And that's why we started to transfer this technique into a minimal invasive approach. You can see here we have done an animal trial consisting of 8 pigs. And we have done in these pigs at least 16 anastomosis. Each pig we performed a side-to-side anastomosis with a lead to the LID on the proximal side, and then to the rema, with the rema as a T-graft from the lead to the distal part of the LID as the end-to-side anastomosis. We had to adapt, to develop the clip, at least the clip applier, slightly, because in this small environment, it is even more demanding to handle and to make movements with this connector technique. So with this adaptation of the technique, we have performed these anastomosis. Next slide, please. And we were successful in most of the anastomosis. You can see an example here on the left side of the angiogram, the LITA with the proximal anastomosis to the LID and with the T-graft rema to the distal part. We had an excellent flow measurement. And next slide. And with the side-to-side anastomosis, we were successful in 7 out of 9 pigs with a good result and good flow measurements. Even the hemostasis was very acceptable. There was only need for 1 additional stitch in 1 pig, and one we had to wait and used some hemostasis glue. With the end-to-side, we were not that satisfied in regards of still technical issues or even the shape of the anastomotic connector is a little bit bigger, and what we had to address the distal part of the LID. That's why we were not that successful. But even with this technique, we can overcome these problems because Elana, Klein has adapted this connector to a smaller size, and in other animal trials we have already successful used this clip. So after we have done, next slide please, this animal trial, we now want to continue with in human trial phase. And first of all, we want to address patients through the mid-cap. First of all, we want to address the Lima LID in open setting, and then in the next trial with almost 60 patients. Next, please. Okay, go back. So we have 2 phases in this trial. The second phase is to address patients in this minimal invasive setting, and we want to include 8 other sites to fulfill these requirement of almost many patients to document and to demonstrate that this technique is also in a small environment not even durable, but easily to handle and successful to use.
Stefan, maybe to interrupt you shortly, there's a question from the audience. If this technique can be done only or on beating heart only, or that we have to put the heart on bypass and arrest the heart. Well, maybe just to comment shortly, I think it's very important to understand for the audience is that we need at least blood flow through the target vessel. And the reason is that during the phase that we make an opening in the coronary vessel wall with laser, we want to have enough heat sink effect in order to make sure that the posterior wall of the coronary artery is not damaged by the laser. So the answer on the question is that at least the patient should be on bypass with beating heart in order to make sure that we don't damage the coronary. Yeah, I think it's a very nice overview, Stefan, really focusing on the minimally invasive possibilities for this technique in order to make sure that we can maybe in the future offer this kind of operation to more patients, or at least with less a burden to the patients. Maybe it's also interesting during the last minutes of this session to focus on the let's say more standardized way of making an anastomosis. I think that we are as cardiac surgeons very good at making sutured anastomosis, but still it is a job that needs to be done by a very specialized person like we all are. And I think this technique could also help our community to make sure that the anastomosis is created in a more standardized way, even more standardized than making by sutures only. And maybe this could also open the way to a higher degree of total arterial bypassing. I think, as we all know, the total percentage of patients receiving total arterial bypasses is actually lower than we still should expect based on patient characteristics like age, for instance. And personally, I believe that with this kind of technique, yeah, we can offer surgeons that still feel total arterial bypass grafting as challenging. We can help these people to make sure that that they also feel more comfortable to do this in the future. Maybe Patrick, Stefan, how do you look at this, let's say, potential perspective for this technology?
I think there's two aspects of it. I think I completely agree with you, Bart, that I think the future of coronary artery bypass surgery is in arterial grafting and possibly also in off-pump surgery, reducing the trauma to the patients, which is not only chest wall trauma but also blood trauma, etc. So I think that's an essential part. I think this allows both, right? So it facilitates beating heart surgery, because suturing on vessels on the beating heart, especially posterior wall, could be challenging, can be challenging. That's one. I think the other aspect is interesting. You mentioned standardization. That is also an important aspect, because we don't exactly know how large anastomosis we make, right? And so we don't exactly. So some make larger endocytes, some make smaller endocyte anastomosis. So this technology also allows us to learn a bit about the relationship between anastomotic size, target vessel, donor vessel, and potential competition in flow. So I think I fully agree, and I feel that this is a great step in the evolution of coronary artery bypass surgery to answer some very important questions and to facilitate both minimal invasive, beating heart, and total arterial revascularization. What do you think, Stefan?
Yeah, and to add this regarding the valve surgery, so we have almost overcome the sternotomy, and many centers provide the minimally invasive access, even regarding TAVI and TEER procedures. And it's the same issue with coronary artery bypass surgery. So over 20 years ago, we still achieved to do a total endoscopic coronary artery bypass. But at least the technique is still rare done almost in the US. But we want to achieve this total endoscopic bypass surgery. And one of the burdens of this technique is that it is technically very challenging because of these very, very limited space and environment. And if you have an anastomotic device, a system, a reproducible tool, this, in my opinion, is very, very helpful to overcome these obstacles. And I believe this is the way how to get more and more adapted and accepted in the community to use this technique. This is not the first step. The first step is, as Patrick and Bart already mentioned before, complete arterial vascularization, ideal on the beating heart, but to overcome all these steps, we should end up in a TCAP situation, and that is why we do not have any anastomotic devices on the market left, except the Elana device, and that's why we put so much effort in to use this technique.
Maybe another question from the audience is that the time to make an or required to make an anastomosis is over 20 minutes. The question is this necessary, or is there an explanation for this? I think I can also answer this question on behalf of you guys, Dave and Patrick, is that yeah, we are still in the phase of the learning curve. We have protocolized and standardized the steps that we consider as necessary to make the anastomosis, and we are really working in a slow motion way in order to make sure that we take the safety in full account, in order to make sure that we don't make mistakes just based on time. So time is absolutely not important. We just focus on safety and making a proper anastomosis. But I think I speculated in the near future, once we have done more patients and we know the outcomes better, that we can easily shorten the time to create this anastomosis with at least 50%. And that is also based on our, let's say, in vitro results that we do during training in the.
Yeah, I completely agree with that. I mean, what we've seen over the last few weeks, I mean, if we're now moving to a larger clip, so it's, I think, also important to add. So these first anastomosis, first in human anastomosis, were made with the smallest size clip we have. So the thoughts were that if we can make it work in the smallest size, it's easier to upgrade to a larger size. So we're now working for the LAD target. We're working with a larger clip. That's one. And what we experienced also, I mean, if there's a lot of it, if you have to define what is anastomotic construction, right? So a large part of what you see in this time is preparing the graft, making sure the laser catheter is in place. So the manipulation part, docking it onto the target and lasering that's only a fraction of the total construction time. So that's only that's like, I don't know, 30 seconds, maybe 45 seconds, very short. So what we see in the lab now, that we can easily do the entire docking and connecting. I think somewhere between 5 and 10 minutes is very realistic for the anastomotic construction. But we see now in our in vitro training rounds. So I think the question is very valid. More than 20 minutes seems to be long, but I think it's also has to do with the first in human experience. Exactly as you said, we can easily shorten this. So 5 to 10 minutes would be a normal procedural time for construction, with only 1/5 of that time the connecting of the complex of the donor vessel onto the LAD or whatever coronary target.
And for the future, this anastomotic device is not created for perfect exposure. This is created while we have or not struggle, but we are faced with an exposure which is not ideal, yeah, in this minimal invasive setting. And so time, I think, is not an issue today, and as you both already mentioned, it will last at least 30 seconds. Yeah, but of course you want to do it very, very precisely in your first cases. The same was with the intuitive valve aortic position. The sutureless valves, it took same time with the sutured valve, because you are not absolutely familiar with the technique. But if you adapt to this, time is not an issue. I completely convinced.
Maybe it's interesting to add another anecdote from, let's say, people that I know from another specialty, plastic surgery. They started to do breast reconstructions recently, and they, let's say, they also have to make an bypass or an anastomosis comparable in size with the LITA and maybe a small vein. And well, during their first reconstructions that were actually quite successful, I also saw the results. Yeah, it took them over 40 minutes to make an anastomosis. So I think it also reflects that, yeah, let's say walking into a new path, into a new trail, like also Stefan is mentioning, that is a challenging trail. Also, it's also meant to be a challenging trail. Yeah, it just takes more time. But I'm sure that. After, let's say, the learning curve phase and after confirmation of safety and efficacy, that the anastomosis time will definitely shorten. But indeed, it is not a primary objective to make a quick anastomosis, like Stefan stressed also.
So Bart, there's another question from the audience. I see that concerning the distal part of losing the distal part of the donor vessel, which is right. So we need, the question is, we are losing a certain part of distal LITA in which the laser catheter is inserted. What's the effort length of the lost LITA? So to fixate the laser catheter, the length you need is actually the length of the fixation device to hold the catheter in place, which is, well, Glenn, correct me wrong, I think it's 2.5 centimeters, I think, so roughly something like that.
A little bit smaller, but yeah, around
yeah,
that.
But you need a little bit more than that. So it's 2.5 centimeter or 3 for the fixation device, but to have an adequate stabilization, keeping it into place to place the fixation device, I would say you need 4 centimeters or something like that in that vicinity. So the longer the better. So to make it easy, we need full length IMAs. That especially in the mid-cap, in the closed chest situation, that will be one of the challenges. Of course, we need full length IMAs. In the open setting, that's usually not the issue. I mean, routinely where we graft the LED is usually I always take some part off in any almost, unless I graft the apex of the heart. So usually you lose a few centimeters anyway. So I think. To be honest, I think we do need a little bit more than what they usually take off, but there's sufficient length to land onto the mid or distal LED.
Yeah, I think that's also how I look at it. I think it's also again important to stress that the margins that we take are obviously larger than we would do in more, let's say, procedures that are more routinely done nowadays. So I think this is also one of the things that we can improve in the near future. But indeed, so far, yeah, we need at least 3, maybe 4 centimeters to just make it easy and to make sure that this is also not an additional challenge.
Yeah, it's interesting to realize that what the essential details that you focus on are other details that you use sutured grafts, right? So it's about stabilizing position, bringing a perfect stable contact position. You just focus on inserting the pins. It's a little bit. It's of course different aspects, and but I think in roughly, I think talking about learning curve part. What do you think? I think we went to a learning curve within a few. How many cases did we do before we felt comfortable? 10, 20?
Yeah, I think. Yeah, maybe. I think you know, we actually started doing this procedure in a preclinical setting, and it's important to stress that in that phase that we did not differentiate steps. We just considered making an anastomosis as just one step. And after some time, we found out that this procedure can be split into maybe 25 or 26 different steps. And as long as we did not, let's say, discriminate these different steps, it was actually quite challenging until we said, okay, now we have to protocolize and to standardize the way we do this. And I think if we now should train a new surgeon, I think we can train this surgeon in maybe a couple of anastomoses that we make. Why? Because the skills that you need to do for this kind of procedure are not special. We all, as surgeons, have these skills. The problem is that you just have to be taught on the steps that you have to make, how you have to make them. So I think a few anastomoses, we can just practice them in vitro in in vitro setting, so not in human, not in animal setting. And I think people can learn this very quickly. Why? Because we control all the steps, and we don't go from step 2 to 3, for instance, before we are satisfied with step 2. So we can very sharply judge if every step has been done perfectly. And again, you don't need special skills. I mean, it's easier than sutured anastomosis, I would say.
I fully agree. And also the standardization you mentioned also allowed us to better evaluate the different components of the procedure. And I think what we've seen that our efficacy of producing a well constructed graft really jumped up after the standardization. I mean, of course, we had a little bit more experience, but the standardization really allowed us to make a huge step in the number of well-constructed anastomoses.
I'm looking at the clock. It's almost 40 minutes now. I think do we have some more time? Are there some remaining questions in the audience or things you would like to discuss or to know? Maybe this is the moment.
No additional questions anymore.
Maybe Klein, do you have some things or points that you want to highlight or maybe to stress, or did we discuss all the important things?
I think everything is discussed. So it's clear that of course there's a learning curve with a new technique. And we are quite happy that Antonius Hospital starts in an open setting, and now we're also working to also a new animal trial, a GLP animal trial with Stefan and also with Timo to make this also the next step to the what is now on the screen, to the mid-cap trial in Germany. And of course, we have the Congress itself, the ESCVS. We as a company will be there. We have there a couple of sessions, also a working session where you can see the technique, see the devices, and also try the devices. So hopefully to see you there in Paris.
Yeah, to add to that, Glenn, so we are working quite hard to be able to show our colleagues a live in the box case of phase 2 patients. So we're in the middle of enrolling for phase 2 for SafeCap, and we already have quite a number of potential patients. So hopefully we'll be able to sort out all the logistics and be able to make a live in the box video over somewhere in the next 2 to 3 weeks, which we will able to show you in Paris on June 15th.
Yeah, great. Thanks. Yeah, I think that was it then. Thanks everybody. Thanks Patrick.
One more question. We see one more small question. How does the anastomosis look angiographically? I think it's a good question. It looks like a normal anastomosis, only there's a clip around, which is I mean, we can't show you any data yet, of course, but angiographically, Angiographically, you just see the connection, and of course there is the material of the clip which is at the level of the anastomosis, which you see. So, but the connection seems like a normal. To me, it seems like a normal coronary artery bypass graft constructed. So, no more question?
All right, so I would like to thank everyone, the audience, my colleagues, and hope to see you again soon, Paris or in Vienna, ESCVS.
Yep.
All right then.
Okay,
Thank you very much.
Okay, thanks a lot.
Bye.
Bye.
Bye-bye.